Like addiction can be so random. Like you can have, 10 kids that always party together and like, for 4 or 5 of them, like it took their life, it completely took everything. And then like the rest of us were able to just kind of move on with life. And, there's so much randomness to that. Obviously there's risk factors, but there's so much randomness to that too. And I think that, I just want the kids to realize that just because you see somebody who's having a great time and doesn't get caught up in it, doesn't mean that it couldn't destroy your life.
Welcome to PodTox Episode 6. We have Marie up here and Dr. Z. We're going to be talking about her life and addiction medicine, stuff like that. So let's go ahead and get into it. First off, we wanted to talk about your childhood and kind of what like growing up was like and what led to where you are now.
So I grew up in Pennsylvania and in just sort of a regular kind of community suburban neighborhood. My mom struggled with alcoholism. And so there was a lot of kind of chaos that went with that. She got sober when I was in medical school, actually. So that was a big part of my, entire childhood. And, you sort of compartmentalize that and you're like, oh, it's fine. Like that's just how it was. And then you realize later on when you kind of get out of that household that like, that's not normal. Like, people shouldn't be abusive in certain ways. And I love her and I don't want to throw her under the bus or anything, but you realize looking back, you're like, yeah, that shouldn't have been like that. Like, I shouldn't have had 2 moms, like one that loved me and supported me and one that like hated me and wanted to ruin my life. It felt like. And then, later on, like I said, a lot of my friends kind of, there were parties in high school. Everybody kind of, did that. And then when I went away to school and came back, I realized a lot of my friends were really swept up in addiction, and it may not have been, fulminant addiction yet. To me, it seemed a lot like they were choosing that. But in retrospect, I realized how early some of them were already like going to rehab and things. And looking back, it just was like, wow, what are the chances? Like, that's crazy. Not linking the two, not linking what my mom went through and what my friends went through at all. Like not seeing that common connection. And then later on, after my friend Tia died from a heroin overdose, it was like the world shook under my feet. And I just thought, oh my God, like here was this friend that we were the same kid. You know what I mean? Like we were the same kid. We did the same stuff. We went to the same parties. And yet I walked away from it and it just took her life. And then I really started to kind of think back to like with more compassion what my mom must have gone through, and that must have really felt like crap. And that when she said like, I'll never do it again, pouring the bottle out, I'll never drink again, I hate that I'm doing this, and then she would drink and I'm like, you liar, like I was so angry. And I sort of started to see it differently, like, wow, she meant what she said and she literally couldn't stop. And I didn't know about any resources. People told me like, oh, you should think about like Alateen or whatever. Like even in school, I remember like a guidance counselor saying that. And, to me that wasn't my world. My world was just, school all day and chaos at night. So anyways, eventually I realized that connection between the world that I had grown up in and the world that my friends had gotten kind of sucked into. And I realized what a powerful force. What a powerful force that you can have your own autonomy. You deciding what you want to do today and how you want to live your life, you can just have that swept right out from under you because of changes that take place in literally your brain programming. So I started to read more about it because they don't teach you enough in med school. And that's something that I'm trying to change. I've been giving lectures to med students and hopefully working with a medical school that's starting up next year on this project. But anyways, they don't teach you much in med school, so I taught myself. And then I decided really to pursue it as a specialty because I just fell so in love with the whole idea of being able to help really I have a real soft spot for the kids, the teenagers that don't know what could come, and the kids that are living in a home with this that think it's their fault and it's not their fault. And I want to give them their mom back and their dad back. I want that kid to when they pray at night, every night, please God, make my mommy quit drinking, or my, whoever with whatever. I want to help that kid get their parent back. And that's what, honestly, I get emotional about that. But That's the goal.
First off, what's Alateen? Is that like Al-Anon but 14s?
Yeah.
I never heard of that. That's kind of cool. I wonder how many people actually go because as a teenager, my dad drank a lot, and I don't think I ever would have gone to something like that.
Yeah, I ended up, instead kind of escaping in my own way. And again, you don't put it together. Like, you don't think like, oh, like me getting drunk at a party tonight is alcohol, and that's what's destroying our family right now. Like, you don't, when you're that
Right.
age, it just, the link isn't there.
Just to talk about your mom for a little bit, did you hold on to some of that anger even still now that you understand kind of more about addiction? Just because I understand that you know how it works, and whenever she poured out that bottle, she did mean it. But I feel like sometimes you can't help but get mad just because they still kept going back to it.
When I can voluntarily like kind of create my own thoughts, I am very compassionate about that. But when there are certain things said in a certain way or something, I can't, I'd be lying if I said I didn't feel those anxiety triggers at times with her, where I'm like, did she just criticize me?
And
Yeah.
it brings you right back, right? It
Yeah.
brings you right back to feeling like
Yeah.
a child again.
Yeah, because it doesn't matter how many diplomas are on my wall. When my mom criticizes me, like it hurts. So yeah, in the voluntarily, I'm in control of my thoughts way, I'm very understanding, but there's still certain things that you work through. I've been through therapy and things about it, and it was very helpful.
What do you think med school teaches well whenever it comes to addiction? Because I've talked to a couple people, and it really doesn't get super far whenever it comes to what they're actually going through. So I'm curious what they actually try and promote whenever it comes to addiction.
So I'll be honest with you. The only thing I remember learning about addiction in medical school was during pharmacy when there would be medications that could become potentially addictive. And there were service projects where people could go and, serve at homeless shelters, and you knew it was a disease of despair, and that, a lot of times it went along with that. I don't ever remember learning like what the criteria were to diagnose addiction. I don't ever remember learning anything about like the family unit and the effects of addiction, the neurobiology of addiction. And I realized some of that was sort of still coming around that time. So I was in med school 20 years ago. And I realized that maybe they didn't know as much then as they know now, but there was certainly, when I look back through old journals, there was certainly some of that, neuroscience was certainly out there, and I don't think they taught any of it.
How much do you feel like the opioid crisis has affected the teaching? Do you think, obviously, they're going to focus on it a lot more, but do you think what they're focusing on is actually important, or is it still kind of very generalized?
I think that the opioid crisis, and I just happened to notice, Larry, thank you for that comment. He said graduate programs in psychology don't teach about addiction either. So we have room to improve, right? But yes, I think the opioid crisis absolutely has put the spotlight on the elephant in the room. I hate that it took that. I hate that it took, 1 million people in how many years to die to be like, oh, like they're people too. And like we have more people suffering from substance use disorders than we have with like diabetes, and it's a big problem. And I'm not saying that to minimize diabetes. They're both serious illnesses. So why with one are we like, this is so important, let's have every commercial and billboard about it. And then everything else is like, oh, those people, that grates my gears. Like, I don't like that. I want to be out there saying like, hey, these people need our care and compassion too.
Whenever you got through med school and everything, did you already have your kids at that time?
No, I had both my children once I was an attending physician. So my first year out of residency, I got pregnant right away. That was a goal. And then I had my next baby 4 years after that.
So you at least had some of you had all the grunt work done at least, so you had a little bit more freedom whenever you had your kids. That's good. That's awesome.
Yeah, although I was still working at a trauma center, so I still worked
Wow.
long hours and, long weeks and those sort of things. And it was when I had the second baby, actually it was post-call, which meant like I had worked the whole like 24 plus hours before. And I was pregnant with the second one, and my oldest one was like 3. And my mom used to help me like watch the kids when they would call it post call, like after that shift. And so she had somewhere she had to be at a doctor's appointment. And so I ended up driving around to try to get the 3-year-old to nap. And I fell asleep driving. And I know.
Wow.
And I woke up, thank God I had my hair in this big bun. And when I like nodded my head back, it hit and it like woke me up. And I swerved and I was like, oh my God, that was scary. I could have killed like me and my unborn child and my 3-year-old. So I ended up like, now I'm awake. I go home and I'm like, oh my gosh, that was so scary. And within like because I was almost ready to have the baby, within a few months of like that, I made the decision not to work the 24+ hour shifts anymore. It just wasn't worth it for me.
How did you balance motherhood with your career? Because I know that's got to be hard because I struggle just as a mother alone,
Yep.
let alone the career that you have and the hours that you have to put in.
Yeah, so it's interesting because, I know people that are, having babies in med school or residency, and I'm like, God love you. Like, I give you a ton of credit. I could not have. I mean, I guess if it would have happened, I'd have figured it out, right? I probably would have surprised myself pleasantly, but I purposely like was trying to plan my family after residency. And like I said, it wasn't always easy with those shifts. Not only was I tired, but actually, to bring it back to my mom, she said something the one day about, me being not around, like, oh, the baby, like my 3-year-old had really missed me because, I was gone all night. And I kind of got a little offended, and I'm like, I'm a doctor, like I'm working. It's not like I'm out like in a band, like I'm like traveling the world and I'm not here for 9 months or whatever. And she said, she was like, well, no offense, but like your kid doesn't know the difference. Your little kid just knows mom's not here. And it was like an axe to my heart. And so between that and the falling asleep in the car and, there were certain things I just always felt like I was saying like, mommy has to go, mommy has to leave, bye. And it really just, and everybody's different and all moms and dads have different situations. But for me, I felt like I wasn't giving 100% to my patients and I wasn't giving 100% to my family. And so that's when I decided not to take call. And now I work no nights, weekends, holidays, other than like volunteer stuff and, this kind of stuff, social media or whatever. And I usually reserve like one day off a week, every week for just, family stuff. So I've definitely balanced it a lot.
That's something I had to learn really well just because I have a lot going on at all times, and I felt like I just wasn't giving my all whenever I was home just because I'd be so tired all the time. So I really had to set aside, even if it was just a couple hours with the kids, I would give them everything in that couple hours, and we would go do something special just so I could make it count.
How did it feel to have your mother start to be a mother at an older age? Like you've already been through med school. Like now all of a sudden she's giving motherly advice, but I bet when you were little, it's hard to get it at an older age, right? And to receive that well.
Yeah, and like I said, triggers and stress, kind of things. But what I have to say is, as confusing as it was as a child, when my mom was sober, she was wonderful. She was the perfect mom, which is, I think, made it even harder that when she was drinking, she was so mean. And it was really hard as a kid to process that dichotomy. And how don't you internalize that and think, well, obviously I've done something wrong, So it kind of drove me a lot to certain types of like perfectionism, thinking like if I was only better at this, she'd love me or be, 100%, she'd be there. She would quit drinking. She would put me first. I didn't think those words, but, through therapy, I realized that there were things that I was doing, like, I'd be like, I clean the house, clean my room, like perfect grades, all of the perfectionism stuff, which actually I'm going to start a series soon on adult child of addiction or adult child of alcoholism, because it is a syndrome. And it is real. And it wasn't until I started studying addiction that I kind of started to put it all together. And I'm like, oh, snap, I have those. Like, I do that.
Yeah.
Yeah. And so I think that it is hard, for the kid to just see those two sides. I think the biggest thing is like, I wish somebody would have said to me, it's not you. It's not you.
Since you're older now and you're in the field that you're in, how much have you and your mom actually discussed this?
So she's spoken a lot to my sister more, and when I say things, she's like, yeah, it's great what you're doing, and that's great, and people need that, and it's a problem, but we don't, believe it or not, really talk specifically about her, drinking, her why, her what. But she didn't go through like a formal recovery or therapy or anything. She just quit drinking.
Also, since I mean, I've got 4 kids, so I worry about them using later on in life. And like the oldest boy, he's been doing some questionable things lately, so I worry about him. Uh, just since you're in the field and you see a lot of this and you can see it from all sides, how would you recommend having that conversation with your child about like, hey, these are the dangers that are out there?
So I can't tell you the first time I started talking to my kids about drugs because it's as early as they were alive. I mean, literally, even when you have and I know it seems silly, but it's part of my routine. I mean, somebody has a toothache and you give them Tylenol and it's like, hey, I just want to make sure you understand this is a medicine and that medicines can help us if we need them, but everything has side effects and risks. And so mommy's going to make sure I give you the right amount. I'm going to make sure it's not expired. We have to be very safe when we talk about medications. And then, as you progress the talk with their age, you can progress to things like, medications are drugs, drugs are medications. We use those words interchangeably because some are prescribed, some aren't, but it's a drugstore, right? It's a pharmacy. And so then I kind of develop, like with my kids, I kind of go into more about how, there are medications or drugs that people may use to change the way that they feel that aren't from a doctor and that could, just like any medication, have side effects and potential problems. And so when I explain it to them, I like to tell them that, what could happen is that at first you're in control of that. And then at some point it can be, there are some things that once you start taking, you could need them. You could need them physically, or you could need them to feel better. And then when you take that away, you kind of start lower than you did before. So I always kind of do something with my hands where I'm like, and when I talk to young kids about drugs, I'm like, this is how you feel like normally. You might use something to make you feel better. And, yeah, drugs feel good. If drugs didn't feel good, we wouldn't have a crisis. We wouldn't have a problem. It's not about how they make you feel at first. It's about what happens after when you take that away. Instead of coming back to baseline, you're now down here. You have to do something just to feel normal. And, I tell people a lot, I tell, the high schoolers, it's true. And most people on this, live will understand this, but they can't believe it when I say I have had clients, patients, clients that use a drug just to get out of bed, to get in the shower, to feel normal, not to get high. Like, not everybody doing drugs is using them to get high right now. Right. And yeah. Like, my patients would be like, oh yeah, I got there 100%, but you explain that to somebody who doesn't understand addiction. They're like, no way. Like, they just, oh yeah, they're just having a great time. I'm like, believe me, get it, not being able to get out of bed, to get in the shower, to get to your meeting or to get to your doctor or to get to work is not a good time. Like, they're feeling sick. They feel like garbage. And it's because we were normal here. We shot for this. You only have so many neurotransmitters in your brain, right? You use them all up here and then you reset, they're not there. So, that's one of the big things I try to explain to teens is that, it all starts with like, oh, I'm independent. I can do what I want. This is my life. Okay. Yep. Okay. But then once you get addicted, what's the first thing you lose? Your independence, being able to do what you want, having your life, all of it. You lose control over your own being. And that's, to me, I think the hardest part of addiction is the lack of control and not being able to pursue what you want in your life because the first priority in your brain becomes that drug or alcohol. And the second hardest thing I find about addiction is that now you're unable to have the same amount of natural joy, right? So when my kid comes off the bus and runs up to me and gives me that big hug, I'm like, oh, like dopamine surge, like it's amazing. And when you take away that ability to feel that natural joy, to me, that's the saddest part of it all. So we're taking away your ability to feel joy and your ability to live your life the way you want, to make your own choices for yourself. And without those things, what do we have,
100%.
So I wanted to ask you a little bit more about your anesthesia career. So when somebody comes in from like a car accident and they're intoxicated, how do you handle putting them under in a safe manner where you feel safe as a physician? Because I know it's important for you to always be in control.
Good question. So having done a lot of years at trauma centers, I could tell you that it's going to go one of two ways. Okay. Either it's an emergency surgery and I have to deal with it, or it's not an emergency surgery and we're going to wait until that intoxication level is safe to proceed. So if somebody has, and I use this as a, if I'm explaining to somebody, oh, sorry, you have to be canceled. Like, if somebody has a knife in their chest, I don't have a choice, right?
Absolutely.
I can't be like, yeah, you have a knife in your chest, but like you're drunk, so we're gonna have to wait because you'll die. Everything in medicine is a risk benefit, and I always show that seesaw, but that pretty much gives you the answer to almost every question. If the risk of waiting is greater than the risk of proceeding, which with the knife in the chest, that's the case, right? Then you have to go through. In a lot of ways, you end up trying to, you could get a quick toxicology, and they do in the trauma bay, and you could see if there's high levels of stimulants or certain things. Alcohol's usually pretty obvious, right? I mean, we can smell it. We can usually kind of see, but polypharmacy, right? So they could have alcohol, fentanyl, cocaine, they could have meth, all of it. So the toxicology is helpful, but it's rare that you have that information. If it's a true door-busting trauma emergency, it's rare that you actually have that information while you're inducing the anesthetic. It's usually more like, you have to put this person under in the trauma bay and then you're all going up to the OR kind of situation. And so you just don't have that information, but you can tell a lot based on their physiology. You could tell a lot based on your physical exam. And I would say if somebody's extremely drunk, oftentimes you don't need as much anesthesia because if you think about it, alcohol is a general anesthetic, really. If somebody is overdosed on alcohol, they're under general anesthesia, right? If somebody throws up and chokes on it, that's while they're drunk, like that's them not protecting their airway. That's the number one risk of, like, that's why we have you fast for anesthesia. So the food doesn't go down your airway. So if you think about it, like it's the same kind of concept is they basically come in under some level of anesthesia. And then you have some some drugs that if they're used in high amounts and for long periods of time can have the opposite effect where, you end up needing so much more anesthetic.
What about surgery on medicated assisted treatment patients? Because so many people ask us questions, right? Yeah. I get it all the time. Like, if somebody's on methadone or Suboxone or Sublocade, like how do you proceed from there?
99% of the time, continue your medication the way it's prescribed. That is at this point in your physiology, and I'm not saying it will be forever, but at this point in your physiology, that's at your baseline, right? And it would be completely, thank you, Jess. Jess said she had a hysterectomy on Matt and was given pain meds, no problem. And that's how it goes. And I was the co-author of a white paper with a company called Envision Physician Services on this topic. And we read so much literature and so many studies to really come up with guidelines for that entire corporation with regards to exactly that, pain management while you're on medication assisted treatment. And the literature in the last at least 4 years, but honestly probably 6 at this time, heavily encourages just continuing your medication at what you're on. So Suboxone, for instance, is, as you know, a partial agonist. Methadone's a complete agonist. So they're going to act on those receptors, but you still have some other receptors, right? So if somebody's on 16 milligrams a day of Suboxone, which would be kind of like an average, right? It's 8 milligrams twice a day. They still have at least 40% of their receptors open that can have other medications given. And as an anesthesiologist, I mean, you break your arm, I could block your arm. I could put the injection here that's going to make your whole arm numb. I can give you things that don't work on opioid receptors like ketamine, like Presidex. We have IV Tylenol. We have, Ketorolac, which is like a Motrin through your IV. So many things. The surgeon can do local in there as well. plus you have that, what, 40-ish% of the receptors that you could still use. And you should use them wisely, meaning that, things with they call it a KI value that's similar to like buprenorphine, for instance, would be things like Dilaudid or like sufentanil. Those kind of things would be the medications of choice for those cases. And there's a ton of literature on it.
Do you have to use those medications at higher levels sometimes when you're in the operating room?
So it sort of depends. What I would say is yes. The short answer is yes. When somebody comes in with a history of high opioid tolerance, usually yes, we do have to use higher numbers. But I will tell you, there's always the element of surprise. And I've had times where I have like a little grandma or a nun or, just an example of somebody who is definitely telling you like never used anything. And you're like, how the hell did they need 650 milligrams of propofol for a colonoscopy? There are always surprises. So for the most of it, yes, you can expect tolerance, but not always.
Have you ever been putting someone under and then notice like, ooh, this person has a tolerance, and like that red flag goes up? Can you tell if somebody abuses drugs, alcohol, smokes? Because a lot of people don't like to be forthcoming with their anesthesiologist, which I always tell people, you have to tell the truth. Like they have your life. They're keeping you alive.
Yeah, it's super important to know what, because the way that I put it is like, what if you were making a cake and you knew all the ingredients that you had in that cake, but you didn't know that somebody put, a cup of vanilla or whatever, like you don't know that's in there. Like the end result of the cake may not be as good. So, it's important to me to know when I'm adding these, strong, potent medications, right? I mean, I can make you unconscious in 30 seconds and then bring you back in as many, like it's crazy, right? So these are some strong things. So we need to make sure that I know what else is in there, either helping or hurting. And so, a lot of times you can tell. We always kind of joke around in anesthesia about, whatever somebody tells you, like when you're training somebody new, like whatever somebody tells you they drink, like pretty much double it, right? I mean, everybody's like, oh yeah, I just have like 1 or 2 on the weekends. And it's like, okay, we just assume more. Now, that being said, it doesn't mean that I'm going to over medicate you from the beginning. I mean, we start an anesthetic dose based on your weight and what we see in your history, medications, and list and those sorts of things. But do we sometimes see signs that somebody's not being honest? For sure. My sign usually, is that nobody can get the IV and they have to call me to get the IV. And you're looking and you're like, yeah, okay. I mean, all of your veins are gone and you haven't had chemo and you haven't had, and that's usually when I'll say, okay, like everybody, step out, and I'll just shut the door and I'll just kind of start to BS with them. Be like, oh yeah, like I practice addiction medicine too. And, this and that. And sometimes in that kind of situation, we see where there isn't a vein, that you could access. And I don't know if you ever went through anything like that, and they'd be like, yeah, I did, but I didn't want to say anything because I was ashamed.
That's the biggest thing most of the time. They're worried they're going to get in trouble or who knows what's going to happen. And I feel like that's a problem a lot whenever people are trying to talk to their doctor or like a random person in the ER or something. They're so worried that they're going to get in trouble or judged or something's going to happen that they will just get shut down, because it does happen. But yeah, I don't know a way that you could technically fix that or make it like a streamlined thing at all hospitals, just because sometimes you're going to get those people that just abuse the privilege of like doctor-patient relationships, and you'll have somebody that just gets videotaped and basically you see them crying because they're in pain or something, and that gets put out there to the world, and like the privacy isn't always there. So I think the worry is always there.
And I like to explain to people too, say, look, like my whole job is your comfort, not just your physical comfort, your emotional comfort. If you come in here and you're scared and you're nervous and you're in pain, like you and I are working together to have you be comfortable through this experience. Our goal is the same. This isn't about me, this is about you. So don't worry about offending me or being embarrassed. Your privacy is maintained. Your comfort is the goal. But yeah, you definitely see that. I mean, stigma kills people. It kills people in many ways, but that's one of them, because people aren't comfortable not only reaching for help. Think about how many opportunities that would be if somebody could be honest and say, yes, I'm using. And I guarantee that there are people who don't come forward with me Absolutely, I'm sure of it. In the anesthesia job. Otherwise, addiction meds, I mean, they're coming to me on purpose, for that. But with anesthesia, yeah, I mean, how many times could you have had a helpful interaction and get some resources, but because of their fear of being judged, and people that work with me in my anesthesia job, like they know, like I'm not the person that you hand a chart to and be like, oh, they're on Suboxone, eye roll, like,
See, I like that.
like, no, that doesn't happen. And if somebody makes that mistake, they will get reminded that that's not cool. Yeah. And the same thing with pain, like pain management. You get people who are like, oh God, they're on like 4 oxys a day or something, and it's like, I feel for them that they must have to deal with significant pain, because obviously it's not like anybody, wants to have more medical problems or more medications on their list. So I think compassion goes a long way.
So I know that you like therapy with your patients, like with your patients that you do addiction medication for. You require them to do therapy as well. Not all doctors do, but I know that I saw that you said that.
Right. So technically, yes, I do require therapy at this point. But I will say that it is like we go out of our way to make it happen. Like we will do Zoom, we will meet
I
you
love
where you
it.
are. We will, if it's a financial problem, if it's a ride problem, like where I am, we are able to be very, very accommodating. So it's not like, oh, you refuse that, then you can't come. I've worked other places where it was just like a checkbox, where it was like, okay, you said you went to an AA meeting or whatever. Okay, I'm just going to check the box. Or maybe they would require, some type of a fax saying like, yeah, they're under our care or whatever. Where I am now, I work directly with the therapists. So that's what I love, 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 because say like we had somebody last week that was having a really bad day, just a really bad day. And she was running late and she had to have my appointment and she had to have the therapy appointment, and we're in the same building, and she was just having a shit day. And we all have those. Excuse my language. I like try never to swear on here. Anyway, she was having a bad day. So we said, look, we only have 20 minutes, so we can't do each the 15 and the 15 because she was late and she missed a bus, and there was, it's, that day, right? We've all had it. And we're like, why don't we do this? We'll all powwow together and make the most out of these 20 minutes instead of you having to repeat your story twice to her, to me. And so the therapist, the client, and I just all kind of got in our chairs and we just powwowed for 20 minutes about what was going on with her, how that was impacting her recovery, and what we could do to help, and what we as a team could do to like move forward. And so that's where I am now, and that's what I love. I think that it's important. Do I think that you can get better without therapy? Yeah. Yeah. I mean, look, like I said, my mom didn't go to therapy and she hasn't drank in almost 20 years. But I think that it's a multifaceted problem that needs a multifaceted response and treatment. And, I think that if I set that example of how important it is, then they'll realize that. I just, if I was like, screw therapy, it doesn't matter, then how am I helping them? Right. Because my prescription is helpful, but it is not going to heal you. You're going to heal you.
What do you use? Do you like handle basically any form of addiction, or is it mainly just you focus on MAT medications, or what all do you work with? Alcohol, stuff like that?
We see all types of addictions. Our therapists also handle things like behavioral addictions, problematic gambling, those types of things, which just, don't typically require MAT. But a lot of times there's a shortage of psychiatrists everywhere, and where I live is no different. And so sometimes I do end up having to kind of help somebody out with, their basic mental health medications. I mean, I'm very forthright about, look, I'm not a psychiatrist. I'm not going to pretend to be the expert on your, schizophrenia or this or that, but, anxiety, depression, like your average things that are a mild version of it that your PCP should be able to handle, so that's kind of where I'll play a role with conditions that don't have a formal MAT program, medication that helps. But yeah, we do lots of alcoholism, lots of opioids are kind of the most common, obviously fentanyl. I mean, to be honest, I've only seen the actual heroin breakdown products on probably 3 or 4 toxicologies this year, all year. I mean, it's all fentanyl.
So with the fentanyl, I know there's a lot with the illicit fentanyl, let me say. I know that because there's a difference, and as an anesthesiologist, like some people might even be scared to get surgery because they're thinking, oh my God, I'm getting fentanyl.
Right.
That's that drug that's killing everybody, because there's a difference between illicit,
Yes.
street fentanyl. So do you have to break that down to patients sometimes? Like,
Yeah.
I'm sure older patients, even of all ages, don't really know.
Yes. And it's no different than propofol, right? I mean, obviously it's different, but the concept that we're speaking of, illicit versus, look at what happened to Michael Jackson. And I would get so many people that would be like, well, you're not giving me what killed Michael Jackson, are you? And I'm like, yes, I am, but I'm giving it in a safe, controlled way. And this is not, us playing whatever we can get away with in Hollywood. Like, this is legit, like, doctor patient operating room situation. And remind me to come back to Jess's question about xylazine.
Yeah, xylazine. That's what I was going to say.
But yeah, so I think you've probably noticed that I do try periodically to make a TikTok about the difference between illicitly manufactured fentanyl and pharmaceutical grade fentanyl, because I think it's so important in so many ways. First of all, legitimate pain patients should not be judged, stigmatized, or looked at as bad because they may be on these same class of medications. If there's something, and I say this when I talk to teenagers, I'm like, look, if maybe you have attention deficit and you and your doctor decided you need a stimulant, this part of the talk is not applying to that. That is you, your doctor, and a legitimate medication for a legitimate medical problem. That's okay. And then we can come back over here and talk about this. And so I do really try to kind of make that distinction between illicit fentanyl versus pharmaceutical fentanyl. But the other thing is, you have people in recovery. I've had patients come in for years ago, even for serious surgeries, that would say, I'm in recovery, I don't want pain medication. And, you got to kind of pull up the stool and stop the action and say to them, listen, I get that. I totally understand that your priority is your recovery, and that's wonderful. But I also need you to understand that this isn't a place for torture. This isn't a place for you to be a martyr. Pain is pain. Recovering addicts have pain. Alcoholics have pain. Everybody can have pain. You're a human. You're going to have surgery. You can have pain. And it would be inhumane of me to not treat your pain. I can minimize those types of classes of medications. But for instance, the hysterectomy, you're going to probably likely require some opioid type of medication. And, our goal is the same, and we can kind of work on that together. Do you want me to talk about the xylazine thing, or did you have?
Yes, absolutely. No, I think that's.
Yeah. So I saw a xylazine wound, and remind you, like, I'm not like street medicine or anything. I know they've been seeing that for a long time. And I have mad respect for anybody who's doing like street medicine and is out there. I love those accounts. I'm so glad to see the humanity and compassion that's going to these people. So I don't say that I'm not doing it to minimize it whatsoever. Au contraire. But I'm just, again, in a like kind of suburban outpatient center that's stable people. So I'm not doing, somebody had asked earlier about like rapid detox. Like that has its role. That's not my job. That's not what I'm doing currently in my addiction medicine practice. So you may find it surprising, but it was the first time that I had somebody with a major xylazine wound just last week. And, she's going now to wound care and having like a wound vac placed and all kinds of things, surgical debridement. But yeah, it was the first time that, I've read about it. I've seen it in other sort of medias, but I've not actually seen it myself. So it kind of breaks my heart because, I'm in my hometown and now I realize like it's there, it's here. So
if you don't mind explaining for anyone that might not know, what is xylazine?
Yeah, so xylazine it's similar to clonidine in what it does like in your receptors. So it's like an alpha agonist, but what it does, it's not safe for humans. It was tested for humans and it wasn't approved. And so it's able to be used in some animals safely. And just, again, we're different beings, right? So it's a veterinarian sedative. So it would be something that they would use through the IV for animals in certain situations. I'm not a vet, so I can't tell you why it's safe for them and not for us, but it was definitely not approved for humans because of risks. The risks outweighed the benefits. And so it's not used in human. The closest anesthetic we have to something like xylazine would be Precedex or dexmedetomidine. The physiology is very similar, but this is something that has been tested and approved in humans. And it can be a really nice medication, but again, it's different. It has a safety profile that's significantly better. And I assume that because of all of the R&R research and everything that had to go into it, maybe that it's very expensive. So, you know, there's some places that won't buy Precedex, won't have it. Again, the generic name of that is dexmedetomidine. I'm sure that there's other brands, but Precedex is kind of the one that's most known in the anesthesia community. Anyways, it's a not as good version of that, right? So again, it's an illicitly manufactured street drug that is either, I imagine in the beginning it was probably being diverted, but there's no way they could divert that much. I mean, that's got to be being made, right? Somebody's synthesizing it. The biggest problem with it, there's multiple problems. One is that it blocks blood flow because of that alpha agonist thing. It has a constriction of blood vessels. And so anytime that you take blood flow away from healthy tissues, you can have your tissues die. Right. So that's why you're seeing these, what we call necrotic wounds, which means your skin and all the layers underneath it should have blood flow to them, and it doesn't. And the blood flow is what keeps them alive. So your skin can just literally necrose and fall off. And that's really scary. And what we have to remember too is that once we get wounds deep enough, I mean, it can travel. People can be septic. They can get heart valve infections. They can have what they would call a septic emboli, which is like pieces of infection just going, you know, the brain, the lungs, and that can cause death in and of itself. It also causes a lot of pain. I mean, they're extremely painful wounds. If you think about it, it'd be like, you know, tying a tourniquet on your finger or something. You're blocking blood flow. Like, that hurts, you know. But the other thing about it is that people are becoming addicted to the xylazine itself, and they're becoming physically dependent on the xylazine itself. So what I've seen and heard and through other addiction forums and kind of following with docs that are treating people on the street is that they'll say that somebody's in recovery. They're no longer like they're on MAT or whatever, and they're not having like cravings and withdrawals and things for their opioid, and yet they're experiencing another separate and distinct withdrawal syndrome. Wow. And it's because of the xylazine. So xylazine has its own addiction, its own withdrawal. And why are they putting it in there? I mean, I can't pretend to know all of the reasons for things, but if you think of this like a chemist who's trying to come up with a certain result, fentanyl's just a faster, higher peak. And they're trying to prolong that to get more like a heroin effect, more like a heroin time frame.
Is that similar to like a brown recluse bite then, because it does the same thing necrosis wise, or?
So I don't want to pretend to be a wound care specialist because I'm not, and I was not the person caring for her wound. But having seen both of those, you know, my understanding is that a brown recluse bite would be a little bit different. And I think those get a lot of MRSA, like methicillin resistant staph, and I'm not sure why. But it's the common denominator of lack of blood flow and nutrients to healthy skin. So hopefully that answers your question, but.
You could also get necrosis from having surgery and smoking prior to surgery, correct? Like if plastic surgery and stuff like that, if you smoke, you have a higher risk factor for necrosis.
So necrosis is really just means that you haven't had like good things coming in and you haven't had the bad things going out. And so it's death of the tissue. Right. So you could have necrosis from anything like, you know, say somebody's bedridden and they don't turn them and they don't have like an air mattress or, you know, cushioning. Like you can get necrotic skin wounds just from pressure ulcers. So really it's, you know, any time that you don't have that healthy circulation, oxygen coming in, you know, toxins going out, so to speak.
Do you think that they're ever going to find a MAT medication for xylazine in the future? Because I saw in the comments.
I do. I haven't really been seeing much of the comments, but I do think they will have a medication for it at some point, just because we already have that class of medication, like I said, with clonidine, Precedex, and things.
That's what Jess was saying.
Yeah, so I'm wondering if maybe it would be even like, I do know of physicians that inpatient are using clonidine tapers, you know, to kind of help people with that initial part. Whether they'll stay on it long term, I'm not sure. There's things like prazosin, which are similar medications that can help with like PTSD as well, and anxiety that's associated with that. So maybe it would play a role. And as far as there was something else I remember reading recently about xylazine, what was that? I'm blanking on it now, but I did just read an article. It wasn't anything that's being studied or approved yet, but it was some kind of theories about treatment for it. I'll have to come up with that. I'll tag you if I come up with it.
What about precipitated withdrawal? This is another question. We're going backwards a little bit. But when you have surgery, so many people on medicated assisted treatment, I get these messages all the time, and I'm like, I'm not a doctor. I can't give medical advice,
Yeah.
obviously. But they're like, oh my God, how do you have surgery? Oh, you can still have surgery on medicated assisted treatment. Do I need to stop? Because their fear
Yeah.
is, oh my God, I did it before. I was sick for days, and they instantly flip out over it.
Yeah. And I mean, there's such a huge anxiety component to that, I remind whenever I do give talks to like other anesthesiologists, I remind them that, the anxiety if people going for surgery that are in recovery is no different than the anxiety of anybody coming to you with a concern. It doesn't matter whether their biggest anxiety is about, their grandpa's driving them, they don't like grandpa driving versus, if it's important to them, it's important to me. Right? Just because it doesn't happen to me doesn't mean it's not important to me. Right? So even if it seems so stupid that they're so concerned about their cat that day, or, nothing against cats. I'm a dog girl. But, but even if they're like, I'm so worried about my cat, and we're like, oh, your cat, geez, come on, you're here for big surgery. That's not the approach. The approach is, this is my patient. They are uncomfortable. They are nervous and anxious about whatever it is. The cat, the grandpa, the recovery. Recovery is huge, right? I mean, because, we want things to be well for their grandpa and their cat and everything, but this person wants to come in and have surgery and not lose control of their life again. That's huge. So, like, that's a big deal. And so I guess, if your question is about precipitating withdrawal, is that kind of what your question
Yes.
is?
Yeah, because so many people are like, well, if I'm on Suboxone and they're giving me fentanyl through the IV, aren't they going to clash? I get that question from so many people.
No. So it's all about what the receptor sees first. Okay, so if this is the receptor and you put a bunch of fentanyl in it, and then you come in with some subs, the subs are going to rip that fentanyl off and slow it down. You could think of precipitated withdrawal like a car that's going like 100 miles an hour. And if you suddenly, the car going 100 miles an hour is your fentanyl, right? And if you now put Suboxone on it, it's like you slowed that car to 50. You're still moving, but you're going to feel that stop. You're going to feel that. So that's kind of what like precipitated withdrawal is. So if you see the fentanyl first and then the subs, you can go into precip. But if you have the subs on the receptor first, the fentanyl just adds on top of it.
That's where the confusion.
Anesthetize you on subs, and that's where like people. There used to be this big movement of like, you have to hold your Suboxone for 3 to 5 days before surgery. And I remember because it was before I was doing addiction medicine, but I was on the trauma committee for the anesthesia. Like I was the liaison from anesthesia to the trauma committee. And I remember like them making these policies and, all this stuff about like, okay, we have to hold this med, we have to do that. And then later on, once I like learned the pharmacology, I'm like, why are they doing that? It doesn't make any sense. All you're doing is disrupting an otherwise stable recovery. You're now increasing the anxiety. You're now increasing the risk of withdrawals. You're now, you're changing things with the pharmacy. And, I am sorry, but that can be a huge pain in the butt. And I know people be like, people dismiss this stuff like it's not important. But if it's you and that's a medication that is saving your life, and now we made it where you may have to go 2 or 3 days without it, that's horrible.
I always tell people, I know you can't always plan surgeries. Emergency surgeries happen. We have situations that arise. But if you're planning it and you can try to talk to your anesthesiologist, or even if you get them in the room right before surgery and you lay it all on the line, hey, listen, I'm in recovery, but also I always tell them like, hey, pain's also a trigger for me, doctor. Right. So please don't leave me to my own vices, because that's not going to be good for my recovery, because I know what works for me and what doesn't at this point. But it's good to have a very clear conversation ahead of time about what your expectations are for the surgery and then post-op as well.
Right. And what you can ask for is an anesthesia pre-op consult. You should be able to ask for that anywhere, even if it's a phone call. You should be able to get somebody from the anesthesia department to call you. And I mean, most places, that is not unheard of. Many people don't know that you have that resource. Another thing that I had as a project several years ago, I founded it was basically that, a pre-op clinic for anesthesia, not specific to addiction meds, although we had a policy on that and we would work with people on that. But also anything. I mean, say somebody, is a Jehovah's Witness and they're not willing to take a blood transfusion. Like, the time to decide that is not that morning, because there are things they could do if it's expected to be a bloody surgery, that they could, maybe take certain supplements, or, maybe some people who would be okay with their own blood coming back to them can donate their own blood. They call it autologous blood donation, so that they would be able to put their own blood in a cooler, so to speak, and then get it during surgery, but they won't take someone else's. There are a lot of really important things that come up that morning that, as an anesthesiologist, you're like, stop, we need to get this together and then reschedule the case. That's a big inconvenience for everyone and a waste of healthcare dollars while the OR's open and the staff is there and the equipment's open and it's to be cleaned again and everything. But that patient, having had 2 back surgeries this summer, oh my God, had I shown up for one of those and found out it wasn't happening, like, So anyways, never hesitate to ask. You can always just ask. Your surgeon would be a great reference to say, how can I contact the anesthesia department if I would like to request an anesthesia pre-op conversation? Maybe
I agree.
This is a great idea. Maybe it's nothing to do with drugs at all. Maybe it has to do with, you're having chest pain.
Or like birth control
Anything.
pills for a woman. Like,
Yeah.
sometimes they tell you to stop them, or like you want to further ask questions, and that's okay.
For sure. Yeah. And when you mention birth control, I do have to tell you, there are a couple of meds that can be given with an anesthetic that can make your birth control not work. There are things that come up that you don't think would. You're like, they're young, they're healthy, everything's fine. And then you have a great question like that. So yeah, I started up that pre-op clinic in 2014, and it's at a hospital that I no longer work at, but it's still going.
I have a lot of people that run into like they don't like the treatment that was laid out, and their doctor isn't responding whenever they try and talk to them about a different form of like post-op care. So they don't know what to do, and they end up getting stuck and maybe not having the surgery and stuff. What would you suggest to a person that's going through that?
So this would be, for example, somebody who's going through surgery and their post-op instructions either weren't clear or they weren't a fan of the approach?
They weren't a fan of the approach and usually it's because they don't want to use pain pills, or they don't want to use too much, or they're worried that they aren't going to work right because they're on MAD or something like that.
Make that appointment. Don't take no for an answer. Show up, talk to them. These are my concerns. Because a lot of times, and this has nothing specific to do with anesthesia or addiction, but a lot of times people call a doctor's office and they get the opinion of the person that answered the phone. That's not why you called. You called to get the opinion of the physician. And a lot of times your question never makes it to the physician. Okay. And I mean, I've seen that in multiple specialties, and I've heard of that. I think it's best to say, I would like to make an appointment with my surgeon. And in the case that you're describing, it sounds to me like it's post-op. So post-operatively, like when people have like a bill or whatever for their surgery, most cases, and I'm sure there's different practice models and different insurances, but in my experience, most cases, your pre-op and post-op care are bundled in with your surgical bill, right? So you are deserving of that question and answer session, whether it happens in one appointment, 2 appointments, whether it happens in the recovery room. Even if you wake up and you don't remember the directions, you should be able to make a phone call and get either somebody that is directly with that physician to call you, or you make an appointment. And sit down and talk to them about it. But the other thing is, and I wish that more physicians thought this way, I'm happy to call the surgeon for my MAT patients. And I will say, hey, I've known so-and-so for years. They're doing really well. Just so you know, these are kind of big triggers for her. Like if she feels anxious about this, or if that, and it's not my job to make that person care, but it is my job to share that information. And I hope they care, but I don't see it as a waste of my time, because I'm your advocate, right? Both as an anesthesiologist, right? You're asleep. If somebody moves something and I don't like the way your arm's positioned, I think that might be sore later. It's my job to be like, we're not putting the arm like that. We're changing the position. That's a huge part of an anesthesiologist's job, is positioning and making sure that whether it's you don't want to lose your partial, or you don't want it, whatever your goals are, those are my goals. Same thing with, same exact thing with addiction is, if you want to make sure that you're communicating with your surgeon and you don't necessarily speak the language, I'm gonna call them up.
That's why I think it's so clear. You have to have that clear conversation ahead of time. That's the thing. And like I've had surgery on medicated assisted treatment where my surgeon didn't really feel comfortable because I was on medicated assisted treatment because it wasn't a surgery I needed to have. So she was like, "Yeah." But what we did is we had a very adult conversation over the phone. And then she wanted me to get a letter. She wanted me to go talk to my primary care doctor and get a letter saying that she was going to prescribe for the first 7 days after surgery. Anything after that, he had to take care of, and he had to write a letter for me. That way it was very clear and there was no gray area. And that's what I always recommend to people. Don't let there be a gray area.
Right. You have the plan and you have the communication, and I want to be your advocate, but you also are the most important to be yourself advocate as well.
Yes.
And where I think it's helpful is, though, I never want you to have that uncomfortable feeling where you feel like your surgeon thinks you're lying or something. And it's almost like a letter of recommendation, right? It's me endorsing you. It's me giving a call and saying, hey, you may have just met this person. I've been working with them for a year and a half. They're reliable. They show up to their appointments. That, this is somebody who I'm trusting in this whole situation, because we all know, we wouldn't be talking about it if it wasn't, active addiction is chaotic. And there are a lot of bad behaviors. But when people are in recovery and they're doing everything right, we certainly don't want to be treating them like they're still in that chaos. When you're getting all your stuff together and somebody's going to treat you like that, it's triggering, it's offensive. And so, I just want to be your advocate in that way too.
And then also after surgery, I always say this, maybe you should check in with your provider that's providing your MAT medication a little bit more frequently. Yeah. If you're a monthly patient, if you're a biweekly patient, maybe you should go weekly, just because they know you. They'll set their eyes on you. They'll notice if something's not right. And you can always talk with them if there is a problem with your pain, post-op pain management. They can lead you in the right direction. They can have a phone call with the surgeon. They can speed up that process.
Mm-hmm. For sure. And I always make sure, also to write my phone number on every prescription. So if there's a question, I don't want it to be the pharmacy complaining to the patient and the patient talking to the person at the front desk and the front desk waiting for me to get done. I want the pharmacy to call me. You have a question, call me. Like, I wrote that. I can clarify it. So, I think we can kind of cut out the middleman too a lot, and it makes it more direct. So, but yeah, surgery while on MAT, it really should not be disruptive to somebody's recovery if done well. And if somebody says to you, oh no, you got to hold that, I'm canceling you, you're on Suboxone, you got to hold that for a week, then I would challenge them to ask if they've read the recent literature, because it's been at least 5 years. So, part of our oath is that we're supposed to keep up with what's new in medicine. It's hard. There's a lot out there, but if you're going to sit there and, tell somebody they're wrong, you better have something to back that up. And you're not going to find it right now. I mean, there are very few exceptions. Maybe if somebody's on a very, very high dose, or, there might be some exceptions, but 99% of the time, you being on a regular dose of Suboxone, 24 milligrams a day or less, you do not need to hold it at all. What you can do, something a lot of people don't know though, and again, I can't give anybody formal advice, so take this educational only, but that Suboxone, it has an analgesia effect, right? It can help with pain, and that its analgesia effect is shorter lasting than its effect of like withdrawal symptoms, right? So the perfect dose of Suboxone is where you're not feeling euphoric, you're not feeling sedated, but you're also not feeling cravings and withdrawal, right? So you can still accomplish that same dose, say it's 16 milligrams a day. Instead of doing 8 milligrams in the morning and 8 milligrams at night, if you're dealing with post-op pain, some people will choose to do, well, either that you can do once a day, or what's best for the analgesia, right, for pain is more frequent dosing. So they may actually do 4 milligrams 4 times a day, because the analgesia or pain relief aspect of Suboxone is you get it for a shorter period of time than you get the other effects of it. So when they use it for pain, when they tell people after surgery, like one of the recommendations, if you're on MAT and you have surgery, is to talk to your provider about it. This isn't me telling you to do this, but you may want to take smaller, more frequent dosing for the analgesia side effect, because that'll wear off in a few hours versus, taking every 12 hours, then you can get that more frequent benefit of that side effect.
I wanted to ask one question. So people that are pregnant per se,
Yep.
that are on medicated assisted treatment, we get so many messages, and Kyle and I have discussed this. A lot of times now, years ago when I first had like my first couple kids and I was on, they always recommended Subutex over Suboxone. Now when I had my last two, they kept it Suboxone, and I know that. I just wanted to hear your answer on why they do that.
So, and I do have a playlist on MOUD and pregnancy if anybody wants more information on that. But what I will tell you is that, you know, we as a medical society, it's evidence-based medicine, right? So we can think certain ways, but until there's evidence and data to support us, you're not going to see a blanket guideline suggesting something usually, right? So the evidence has been fairly recently, like in the last 5, maybe 8 years, has been going more towards, look, you're probably fine to have naloxone while you're pregnant, and it's probably not going to hurt anybody, so it's most likely fine. And then they can kind of, you want to see them repeat that, right? You want to see more studies showing, oh yeah, there were no side effects, there were no problems. It's very, very tricky to try to do research on pregnant women. It's an ethical dilemma, right? Because you have this little baby that can't consent. Even if mom consents, the fetus can't be like, sure, try naloxone on me, you know? And so it's an ethical sort of dilemma to try to do. So what they end up doing is retrospective analysis. So like, okay, well, this person was on Suboxone and they did fine. Looking back, not saying, hey, you're pregnant, you're my guinea pig kind of thing. And so to answer the question as to why, though, they technically had classified naloxone as a class C, which meant that it wasn't known to be safe in humans in pregnancy. Like they couldn't say that it couldn't cause harm. So if they can't say it can't cause harm, then they can't recommend it, right? And so I think what you had was some data coming out to say it's probably okay, but you had a lot of doctors that are scared too, because, you know, and I know most people don't feel bad for us in this way, but you have to realize that, you know, there are so many, like if somebody's mad at a doctor, what do they say? I'm going to sue them. Like, there's so much of a litigious society that we live in that if it's just a matter of like writing Subutex versus writing Suboxone, but you're afraid that if it is harmful, somebody's going to come at you, or if that baby has something unrelated as a problem, that they're going to come at you and say it's your fault. And when it's a class C, you're scared. You're like, what if there is a problem? Or what if there isn't?
Yeah.
Somebody wants to sue me about it. And, you know, there's 18-year statute of limitations on a baby. Like, you know, God forbid something go wrong. You know, I mean, you may have a 7-year thing, right, that you could be sued for something. But with a baby, it's 18 years. And, you know, number one priority is that baby and that life. But somewhere down the line, you do have to think about your own kind of, you know, you want to be able to practice medicine, right? You don't want to be getting sued for, you know, frivolous things.
I feel like that has kind of become the big worry for all doctors because and I have the same problem. I get pissed off about what some doctors do, and other patients get mad because no matter what, they feel like they aren't getting the care that they deserve. But that is the one thing that I try and make sure everyone keeps in mind. Every doctor has to worry about losing their license or getting sued or some sort of like bad thing happening, no matter what, even if they make the perfect decisions. If the patient doesn't like it or anything goes wrong, it can come back on them. So it's a hard fight to kind of have, just because there's always going to be someone who takes advantage of somebody else.
Right. And, you know, it's hard too, because, you know, that's why, for instance, that's why I can't give medical advice, right? That's the whole reason I can't give medical advice on TikTok. Because once you do that, then you establish what's considered a patient-physician relationship. And now that person could say, oh, she abandoned me. She established this relationship, and then she never contacted me again. And you know, what do I have? How many followers? I can't have that many patients on my
right.
person. So anyway, it is sad because I would love to be able to like I get inbox messages where somebody will be like, you know, hey, how can I do this? Or how much of this should I take? And, you know, I have to be very clear with like, I'm not allowed to give medical advice, but I can educationally tell you that hypothetically, a lot of people have luck with XYZ. You know, I kind of skirt around it.
Yeah, because
there's ways.
Does that with us a lot too. Like they want the exact answers for like how to taper and stuff like that. It's like, I can't tell you that. I'm sorry. Like, one, I'm not a doctor. I've helped a lot of people off some stuff, but I can't honestly tell you what's going to work for you.
And everybody's different too. And that's again, it's, there are people who are like, hey, I would never want to take Suboxone. Okay, like that's your recovery, that's your story. You do you, and everybody's different. I personally support all paths to recovery. If you're a better version of yourself today than you were yesterday, then you're winning. And I see a few people asking about Sublocade. Do you guys want to talk about that a little bit?
Yeah,
Okay.
I did actually want to talk about so if somebody came into your office and they were struggling and you were trying to figure out the best treatment for them, is there like a guideline for why you would put them on maybe methadone or subs or put them on Sublocade after a little bit, or how does that process kind of work?
So I think one of my first questions is, okay, what have you done before and what's worked for you, right? Because I'm not this person that thinks that, I have some magic where, okay, you've tried Suboxone 15 times and you hate it, and yet my prescription's somehow miraculously going to be better. Like I take your word for it that that's not what you want. And so I usually do try to meet you where you are and start there. Now, that being said, I don't personally prescribe methadone, not that I have anything wrong with it, but because for those of you who may not know, there's a lot of bureaucracy and red tape around methadone, and it has to be at a certain type of facility, and that's just not where I currently work. So I'm not legally allowed to be passing out methadone where I work. But I do believe that for some people that is needed and that is necessary. And I think it's in my mind, I think of it as usually somebody who Suboxone is not going to take away their cravings and withdrawal symptoms enough, right? Because there's only so much action you can get at that receptor with a partial agonist. And a lot of people do really well with buprenorphine, or the generic name for Suboxone. A lot of people do really well with it, but some people won't. And so there will be some where it's like, look, you're on a reasonable dose of it, and yet you're still craving and you're still feeling dope sick. I think you might benefit from a higher level of opioid activity. And then if you want to get to that, get stable, right? Because it's all about your life, right? Maybe, if you're still struggling and you don't have an apartment and a car and a job and your kids back, then we need to kind of like stop the bleed, right? It's just like a trauma. You got to stop the bleed, stabilize the situation, and then reassess. So I've had times where I've said that to somebody, and then they go to a methadone clinic, and then like 6 months later, they're like, okay, things are kind of chill in my life now. I see what you meant. And like, now can we get on the subs? And we can.
What about Sublocade? Are you seeing people that are like using that longer term? Because most people, the whole purpose of Sublocade for them is I'm going to get on the shot so I can be on it for a few months and then get off subs altogether.
Right. It's a nice wean. It's an easier wean. It's less laborious, right? I mean, they're not sitting there cutting things, right? Marie knows she did it. Congratulations.
Thank you.
But I have no problem with, if you just like the convenience of the injection and you'd rather do that once a month versus dealing with, maybe you have little kids that put everything in their mouth and you don't want to have strips or tabs in your house, or it's just a pain to go to the pharmacy. Or I had one person want to go to the shot just because of the BS they were dealing with at the pharmacy. They were being rude to them. They were not being kind to them. It was almost passive aggressive with like, oh, it won't be ready till Monday. It's like this power trip, and these people are like, like, I just want my medication. Like, would you do this to a diabetic, So I'm a big fan of the shot. No, I'm not sponsored by, the Indivor, whatever company. I'm not sponsored by them. I know I get accused of that sometimes in my TikTok.
Me too. I've had people say that.
I'm like, no, I'm not. But what I see is I see the mom with the toddler who's crawling around on the floor of the office. And I know what that's like as a mom. And it would be hard as hell to be trying to cut my strip or take my strip or deal with that and have the kid and like, don't grab this. And the curling iron's hot. It's crazy. If I could go in once a month and get an injection, if I were in that situation, that would be my choice. And I would do it as long as I needed to do it. And then what a lot of people will do is they'll say, okay, well, I'm ready to wean now. I think, I've been on the shot for a few months. And you probably know the first 2 injections are recommended to be higher doses, like a loading dose. I explain it to my patients like a Z-Pack, right? If you take a Z-Pack, you may have taken a couple pills the first day and then one every day. It gets you a steady state, but it gets that steady state started sooner. And so anyways, with that, I forget what I was saying about that. Oh yeah, if they say that they want to stop, the injection, basically we'll kind of space it out to 5 weeks instead of 4. Be like, how you feeling? How you doing? You all right? And if sometimes it's an anxiety component, sometimes they're like, oh my God, I couldn't, I was thinking about it, I was nervous, I was anxious, but I didn't feel sick. It's very rare that at that period of time that somebody would have withdrawal symptoms. But again, everybody's different, and rare's only rare if it doesn't happen to you.
I feel the same too. I love Sublocade. I could scream from the rooftops about my Sublocade experience because I literally felt that freedom, and I started to feel like a cloud lifting off of my head. Like, I don't know, just even my sleep. That's one question I would like to ask you. So when I was on Suboxone, I had eight years of insomnia, and my doctor's thinking that it was the Suboxone that was the naloxone and the Suboxone, because once I got on Sublocade, boom, I could sleep.
Wow.
It's
Were you taking it at night? Were you taking like two times a day, or all in the morning? Or
I would take it all in the morning, like 1 o'clock in the morning. That's when I would wake up. I could not, I would sleep for like 1 or 2 hours max for 8 years.
That's surprising. I never knew that. But you know what? This is what I would say if you were my patient in the office. I'd say, I've never heard that before, but I believe you, because everybody is different. And, then I think in those sort of situations, you may have to go through getting a prior auth or something, but you just try the plain buprenorphine. I don't see this as like, you're out to scam me and I have to be so careful. Like, there's always going to be bad apples in every bunch, but the vast majority, the vast majority of people seeking addiction medicine treatment that I've met really want to get better. And so I think that, that would be a situation where I'd be like, okay, screw the naloxone then. Let's just try Subutex. Like, I believe you.
Isn't there a new weekly and monthly shot coming out?
Brixadi, I think is the name,
Yes.
right? Brixadi.
Yeah.
Yeah, so I just recently had some information sent to me about that, because I think that the rep's going to come give us some information.
I love that.
So I'm not sure. I think it's a subcutaneous. I apologize. I didn't.
It is actually. It's a shot like Sublocade. Supposedly, they have a weekly injection and then they have a monthly one.
Right.
They have it in different doses.
There was briefly one that was subcutaneous. It was like the rods for, it was like Probufene. What was it? Am I saying it wrong? I forget. There was one that I never actually used. It went off the market quickly, but it was like a Sublocade, but it was supposed to last for like 6 months or something. It didn't last long. So, you never know.
What about that ear device? I get questions about that ear device a lot. I know what my beliefs are. I just want to hear about yours.
So I'm not opposed to trying anything like that. So the way that I look at it is, again, risk and benefit. I mean, if it's a little stimulating device and we have no reason to think it does any harm, why not try it? There are other things too. We had talked briefly earlier about how some drugs don't have MAT, like methamphetamine. There are some electrical stimulating kind of devices coming out that are being researched to try to target certain areas of the brain for people with methamphetamine addiction. I think that in 5 or 10 years, there's going to be a whole different subset of treatments that we don't even know about right now. I pray and I hope.
What about Ibogaine? What's your thoughts on Ibogaine? Because I hear a lot about that as well.
I think, again, it can be an option in the tool belt, for some people. I personally don't have experience using it, but I wouldn't be opposed to learning more about it.
Ketamine? What about ketamine?
Yeah, so
with like mental health.
Ketamine has a lot of untapped resource, I think. So, for instance, when I was just at my, anesthesia job, when I was telling you about the trauma center that I had worked at several years ago, one of the doctors that was doing like a ketamine infusion for people that had refractory depression, they were on vacation and they asked one of the anesthesiologists to stand in and kind of oversee this. And all of my partners were like, oh my God, I'll never do that. That's so scary. What about this? And what about that? And I'm like, I mean, he's doing it already. It's met through the hospital protocol. Like, I want to learn something. So I said, I'll do it. It was like cool. 2 milligrams of ketamine an hour. It was like this teeny tiny dose. If I put you to sleep with ketamine, I'd probably give you 150 milligrams of it all at once.
So it's a microdose. So essentially it's a microdose.
Tiny dose. And if this person has tried everything else for their depression and it hasn't worked, why wouldn't we offer something like that? Because depression's a potentially life-threatening disease. Addiction, a life-threatening disease. I think that it's time that we start thinking about, outside of the box and trying different things. Obviously those have to be tested and done in a regulatory manner. But I think that I'm open to all of those ideas.
Do you guys have a system if there's certain pills that are going around that are like really affecting the community and they're in all the schools? Is there a system that you doctors have that you're like, hey, it's in our area?
No, and I wish there were. What we do have some conferences. There's one that I go to that I listen to every year that like our Pittsburgh Children's Hospital puts on, and that's really nice, and they'll talk about trends. Otherwise, every year I attend the ACMT conference, the American College of Medical Toxicologists, and they talk about all the new, they call them NPS, like novel novel psychotropic chemicals or something. I forget what they call it. Sorry, I just blanked. So whatever it is, I listen to their talk every year because they'll talk about the trends, like what's going on. There's also websites, and I have a couple TikToks where I put the links. I don't know them now, but there are some websites where you can look in your area and see what the harm reduction community is doing. And this is why, I hate when people, put down the harm reduction community and say like, oh, they're allowing people to do drugs. No, what they're doing is they're collecting information, they're distributing resources. This is a vital link that we absolutely 100% need. None of us can say, I alone in my society is going to solve this problem. We all need all of these resources to solve these problems.
I think that they should have a system like that in place where it's like, when emergency broadcasts, like on a phone of an Amber Alert, but hey, this is coming into our hospitals. This is what we're seeing. Like, hello, like that.
That's a really good point. I think that there should be some type of an alert, like think about what we all just did with COVID, where it's like you have something saying, hey, there's this strain. Hey, there's that going on. Hey, this is particularly deadly. I think that would be great. The emergency medicine and toxicology, I don't want to speak for them. They may have something that I don't know about. But otherwise, the ACMT has been really helpful, and, just public messaging. Like, I mean, that's how everybody knew about xylazine before it came, right? Is that everybody's talking about it. And, don't get me started, but, for instance, there was a study on Caesar. I don't know if you guys follow Caesar at all. They talk about this kind of stuff, like what drugs are around. Yeah. And they were saying about like a pop quiz about how many places, what they actually test for in their toxicology. And the majority of them aren't even testing for fentanyl.
Wow.
So they're definitely not testing for xylazine. I don't have a xylazine test in my office, and I need to get one. So, we're all unfortunately a little bit behind the 8 ball.
So I wanted to go back a little bit. How are you doing on time?
I have a few minutes. My 8-year-old's been entertaining himself, so he's just watching TV.
Been a good trooper.
Yes.
So I'm trying to pick the thing I want to ask because no matter what, it's an interesting topic. So with Sublocade, I have had a few people come to me withdrawing off of Sublocade, and the last thing I want to do is scare anybody because it gets intense. Every single person that has came to me withdrawing off of Sublocade, it didn't start for like a couple weeks to like 2 or 3 months.
I've never had somebody come back after going off of it and say that they were having like significant withdrawal. Never.
So I'm learning that part of it is the way the doctor that gave it did things. Like either they gave them too much and then pulled them off like super quick and stuff like that. It's if things are done incorrectly in somewhere. But every single person that's gone through it it's just been like months of it doesn't get better, and I don't know what to do about that. Like, is the only option getting back on subs because it's in your system for so long?
Right.
That's the thing that scares me whenever it comes to things like that.
I think it depends on the person and their unique situation, but keep in mind that the Sublocade shot, even though we have this concept of like it's there so long, it's in teeny tiny amounts, right? So when you have the injection active, right? Say you've done your your jumpstart 300 2 months in a row. Now you're at 100, and you're at a steady state. You're at like 2 nanograms per milliliter, like the level of what is in your bloodstream. So it is considered like the same as if you were on like 8 milligrams twice a day. Okay. So then once you stop taking that, that goes down slowly over time. The way I describe it to my patients is kind of like, the jawbreaker candy, and it's like it's red and then it's purple and then it's blue, like layer upon layer upon layer. So you've like the medicine and then the liposome, which is like fatty stuff that your body kind of breaks down, and then you have the medicine. And so it's like constantly kind of just getting a little bit left, and over time you're getting less and less and less. I've had people who came back for, unrelated things that we got a tox on, because we still, even if they don't see me anymore, if they're still seeing the therapist, they still get their toxicology and everything. So I've been able to see people's toxicology results after they're off. And you'll see buprenorphine levels very, very low amounts, less every month, and it's coming down, but you'll see it for 6 or 8 months. So yes, it's there a long time, but it's not in a very high level. So if that person needed to get back on subs, I wouldn't think like, oh, well, we have to wait till you get down to 0 or anything. I mean, they could certainly get back on them. It shouldn't be all of a sudden you have all these symptoms because of the pathology. It really shouldn't be. So I think there should be some time for planning. If, call sooner than later if you think you're having a problem, with that. And how much of it is anxiety?
That's what I was saying. Yeah. So Kyle, honestly, being somebody that's been on Sublocade, I get so many questions as well. Most of the time that people are psyching themselves out and making themselves think that it's withdrawal, when they're just, because they're learning to really truly feel their feelings again. That could be very overwhelming, and it could be misplaced as withdrawal. Do you agree that sometimes, because the cloud's starting to kind of lift and it's like all of a sudden they're anxious, no different than coming off of subs. You're like, oh my God, is it this? Is it that?
And I try to explain that to everybody so much. It is almost completely your mind, because you can convince yourself, no matter what, that you are not going through withdrawal. You may have a few things, but I've been able to distract myself out of methadone withdrawal and be almost completely fine. So I know you can do it.
I did a post not long ago. I stitched something that Recovery Mike had said, and I loved that TikTok of his so much that, it's true. It's around that like 3 to 6 month, or sometimes 6 to 9 month mark, can have really significant anxiety. And I think that's another great reason. Don't assume that because you don't need medications anymore that you don't need therapy anymore, or groups or peers.
Exactly.
Super important to still check in. And I always tell my patients, like, you're still welcome to come see me. There's not like there has to be a prescription between us for you to be able to come tap into my resources, period. Like, you want to make an appointment every week with me, you can, however often you want to, or maybe you just want to check in 3 months. But I'm never shutting that door. You and I are, I'm willing to do whatever it is, whether or not you need medicine.
Because accountability for me was a huge piece of coming off of the Sublocade. I wanted to see if I could really trust myself. So I wanted to make sure my doctor had one shot there that's held in the fridge for a year, up to a year. And the other thing is, because a safety plan, when you're coming off a medicated assisted treatment, and I'm sure that you recommend this to your patients as well, a safety plan is everything. I want to go check in with my doctor. I just checked in with my doctor and had a false positive, but my doctor was like, don't worry about it. But a lot of times setting up those things are very important coming off of medications.
Yeah, more so than before even, right? Because, there's a certain level of a life jacket that maybe, you don't have on at that moment. And so I, a lot of times would explain recovery also is like, you're in the river, you're in the water with the, it's easy to feel good and comfortable when your head's above the water, right? It's when the water gets rocky is when you really need some extra support. And so around that time, think of all the things coinciding. A lot of times people are finally getting, their court dates settled. They're getting custody of their kids back. Their family's sort of starting to kind of reintroduce to their life maybe. It's a stressful time. And, talk about it to your peers, talk about it to your doctor, to your therapist. We're here for you. Use your resources.
We don't want to take you from your family for too long. So Marie, you got any last minute things? I think I am good.
I just wanted to say thank you so much for
Yeah.
everyone that stayed in this live, that's
Yeah,
joined
thanks,
this
guys.
live. Thank you. I know that you guys got a lot of really valuable information today, and I appreciate your time.
Thank you very much. Thank you everybody for joining. Don't forget if you want to subscribe, there's a little star thing I think like right there. You can hit that, subscribe, show your support. Don't forget to follow all of us. Do you have any other like Instagram or anything like that you want to plug real quick?
So I'm on Instagram. I'm not really good at it. TikTok is kind of the one that I'm like I got like reasonable at making the quick videos. I am working on my YouTube, so I'm starting that, and I will put a link on my bio whenever I get that figured out. I'm
If you
kind
need
of
help with
Perfect.
YouTube, let me know because I got you on that because I think you would do great in YouTube.
okay.
Absolutely.
Cool. Thank
But
you.
heck yeah. All right, guys. Well, thank you very much for coming in. We appreciate your time. Seriously. Thank you, everybody who watched. We love you all, and we're going to head out.